Thomas is with us from Chennai. And also we have an excellent panelist, Dr. Davis Paul, Dr. Ennis Davis, and Dr. Murali CP is there. So my duty is to welcome all. So initially I welcome the President of IMA, Dr. Joy Manjula, who is always the most vibrant president ever I had seen, conducting all the programs of all the specialties. So welcome you, sir, to this webinar. Now, I welcome the chairman of IMA AMS, Dr. R. Indudharan, to this webinar of World COPD Day, and also the convener of IMAMS, also our young vibrant secretary, Dr. Unniar Baby, to this webinar. Also the secretary of IMA, Dr. Pavan, to this webinar. Now it's my duty to welcome the speaker of the day, Dr. Prasanna Kumar Thomas, the great orator, the great speaker, and the most humble person, the most jovial person, I can say that. We want you here actually, sir, but unfortunately it's in a webinar. So anyway, we will at present COVID time, so there's no option. So welcome you, sir, to this webinar. Also, I welcome the panelists. Of course, you all know them. Dr. Davis Paul, sir, who was the backbone of pulmonology in Thrissur and who is at present head of the Department of Respiratory Medicine in Amala. Welcome you, sir, to this webinar. Also, I welcome Dr. Ennis Davis, the head of the Department of Pulmonary and Critical Care Medicine, Amala, who is my friend, my classmate, and my colleague. Welcome, Ennis. And also our most vibrant young man from Medical College, Dr. Murali CP, sir. Welcome, sir. So I welcome each of you, each of the APT members and each of the IMA members to this excellent feast of COPD Day. Welcome all of you again, once again. Thank you.
Thank you, Dr. Jodo. Now I invite Dr. R. Indudharan, Chairman, Academic Medical Specialties, IMA Thrissur, for his felicitation. Over to you, Dr. Indudharan. Hello? Unmute and talk. Unmute you.
Unmute ആയല്ലോ. എല്ലാവർക്കും നമസ്കാരം. വാസ്തവത്തിൽ ഒരു ഫെലിസിറ്റേഷന്റെ ആവശ്യമുണ്ടെന്ന് എനിക്ക് തോന്നുന്നില്ല. വി ആർ ഓൾറെഡി ലേറ്റ്. നമ്മൾ ടൈം കീപ്പ് ചെയ്യാന്നുള്ളതാണ് പ്രധാനം. എങ്കിലും എനിക്ക് അസൈൻമെന്റ് തന്നിട്ടുള്ള കാരണം ഞാൻ പറയുകയാണ്. പ്രിയ സുഹൃത്തുക്കളെ, നമ്മൾ ഇന്ന് ഒരു ഉയർന്ന എനർജി ലെവലിലാണ്. കാരണം നിങ്ങൾക്ക് എല്ലാവർക്കും അറിയും പോലെ തന്നെ സംസ്ഥാനത്തെ ബെസ്റ്റ് IMA ബ്രാഞ്ച് അവാർഡും AMSന്റെയും CGPയുടെയും വിമൻസ് വർക്കിംഗ് കമ്മിറ്റിയുടെയും ഒക്കെ രണ്ടാം സ്ഥാന അവാർഡൊക്കെ കിട്ടിയതിന്റെ തിളക്കത്തിൽ ഈ COPD ഡേയും അതിന്റെ ശാസ്ത്ര പ്രഭാഷകരും നമുക്ക് ഒരു പുതിയ ഉണർവ് തരുമെന്ന് ആശിക്കുന്നു. പ്രത്യേകിച്ച് ഞാൻ മനസ്സിലാക്കിയിടത്തോളം ശ്രീ SP ബാലസുബ്രഹ്മണ്യത്തിനെ ചികിത്സിച്ച ഹോസ്പിറ്റലാണ് MGM ഹോസ്പിറ്റൽ എന്നാണ് എൻ്റെ അറിവ്. ആ MGM ഹോസ്പിറ്റലിൽ നിന്നൊരു പൾമണോളജിസ്റ്റ് വരിക എന്ന് പറയുമ്പോൾ SPBയുടെ സർവൈവൽ കാര്യങ്ങളും നോക്കി നടക്കുന്ന ഒരു ടീമിലെ മെമ്പർ ആയിരിക്കും ഇദ്ദേഹം എന്ന് ഞാൻ കരുതുന്നു. ഇന്നത്തെ സ്പീക്കർ ഡോക്ടർ തോമസ് തീർച്ചയായും വളരെ അപ് ടു ഡേറ്റ് ആയിരിക്കും ആ ട്രെയിനിങ് കാരണം. അപ്പോൾ ആകാംക്ഷയോടെ കാത്തിരിക്കുന്നു ഞങ്ങളെല്ലാവരും. ഓരോരുത്തരെയും പ്രത്യേകം ഞാൻ എടുത്തു പറയുന്നില്ല, എങ്കിലും ഡോക്ടർ ജൂഡോ, ഡോക്ടർ തോമസ്, ഡോക്ടർ ഡേവിസ് പോൾ, ഡോക്ടർ എനിസ് ഡേവിസ്, ഡോക്ടർ മുരളി, എല്ലാവരും കൂടി ഇന്നത്തെ സായാഹ്നം വളരെ ഗംഭീരമാക്കുമെന്ന് ഞാൻ പ്രതീക്ഷിക്കുന്നു. ആകെ എനിക്കൊരു വിമർശനം പറയാനുണ്ട്. നമ്മള് COPD മാറാരോഗം, കൊറോണ മാറാരോഗം, ഞാൻ ചോദിക്കട്ടെ, ഡയബറ്റിസ് മാറാരോഗം, ഒരു സൂക്കേടുകളും അങ്ങനെ മാറുന്നതല്ല. നമ്മൾ അസുഖങ്ങളെ വെച്ചിട്ട് മനുഷ്യന് ജീവിക്കാൻ അസിസ്റ്റ് ചെയ്യുകയാണ്. അപ്പൊ എനിക്ക് ഈ കൊറോണ തന്നെ മാറില്ല, ഒരു മരുന്നുമില്ല. എന്തൊക്കെ മരുന്നുകളാണ് നമ്മൾ പ്രയോഗിക്കുന്നത്. ഒരു പോസിറ്റീവ് കാഴ്ചപ്പാടോടുകൂടി ഈ COPDനെയും എല്ലാ അസുഖങ്ങളെയും കാണണം എന്ന് അഭ്യർത്ഥിച്ചുകൊണ്ട് എന്റെ ഫെലിസിറ്റേഷൻ കൊടുത്തു. താങ്ക് യു.
Thank you, Dr. Indudharan, for your felicitation talk. Now I invite Dr. Unniar Baby, Secretary, Association of Pulmonologists Thrissur, and Convener, IMA Academy of Medical Specialties Thrissur, for his introduction of the faculties today. Over to you, Dr. Lee.
Thank you, sir. Thank you, Joy, sir. Good evening to one and all. Directly go into my duty, and we are already 10 minutes late. My duty is to introduce the speakers for today. The main speaker for today is Dr. Prasanna Kumar Thomas, sir, or as he is popularly known as PK Thomas, sir. He is as Judah sir has already said, a wonderful speaker, a great human being. He has done his graduation and post-graduation from Madras Medical College, and he was a recipient of KV Krishnaswamy Gold Medal for the Best Outgoing MD Postgraduate. He is currently working as a senior consultant pulmonologist at Sri Ramchandra Institute of Medical Sciences and also at MGM Healthcare Hospital, Chennai. He has around 40 years of working experience as a pulmonologist. His basic areas of interest are airway diseases and smoking cessation, and he is actively engaged in promoting and continuing medical education for professionals and smoking cessation for the public. He is an international speaker. He has given guest lectures at various international conferences, including WASSOG conference in 2017 on sarcoidosis and TB, and also on annual congress of Philippine Chest Society on phenotypes of asthma. He's also actively involved in social sensitive activities like pre-medical camps and awareness program, and he has done multiple such events all over India, including remote places. And his vision is a tobacco-free India, and his dream, and that is his dream and a vision, and he's a reflection of the person that he is. With all sincerity, I humbly welcome you for this conference. Thank you, sir, for accepting our invitation. I welcome you, sir.
Thank
We
you
also
very
have
much.
we also have a panel discussion post his invited lecture. The panelist has already been introduced. It is known to all the participants here. Dr. Davis Polsa, who was a former head of the Department of Pulmonary Medicine at Government Medical College, currently working as a head of the Department of Respiratory Medicine at Amala Institute of Medical Science, Thrissur. And here also we have Dr. Rennis Davis, who is the head of the Department of Pulmonary Medicine at Amala Institute of Medical Science, heading the DM department. We also have young dynamic Dr. Murali CP, who wears multiple hats, working as a resident medical officer as well as an assistant professor at the Department of Pulmonary Medicine at Government Medical College, Thrissur. It's my honor and pleasure in inviting all of you for this meeting. Thank you.
Thank you, Dr. Kumar. In between, I forgot one thing. I congratulate Dr. R. Indudharan and Dr. Unniyar Baby for achieving the AMS award for the second best branch of our IMA Kerala State branch. Thank you very much for your cooperation and everything. Thank you very much. And now I invite.
So we are just a face. You are the kingmaker.
No, like that. It's a teamwork, you know.
Right.
It's not a one-man show. Now, you go ahead with the program. In between,
Yeah.
let me leave this program because I have to attend the image meeting that started, like the president and state secretary left. I'll be going for the image meeting, and in my place, Dr. Santosh Babu, senior vice president, will take the charge. Okay, thank you, and carry on with the program.
Thank you.
Okay.
Thank you, sir. Sir, I will directly go to the first topic. Prasanna Kumar, sir, I invite you for your presentation, sir.
Thank you. Thank you very much.
I request everybody else to all other participants to kindly mute their phone and speaker.
A very warm good evening to one and all. It's a pleasure and a privilege. Chennai today is like Kerala. It's raining cats and dogs outside and very windy. And I had to wade through the water to come back home from hospital. So I think it's looking a lot like your place, and I think I was reminded of that only. It's a great pleasure, a privilege, and an honor to be here. I thank Dr. Judo and the Association of Pulmonologists in Thrissur and the IMA for having given me this great opportunity. I consider it, I'm hugely privileged and honored to be here and humbled by the same. We'll now talk about COPD and look at what India thinks about COPD. Is there an Indian variety of COPD, if at all there is one? Is there a Western variety of COPD? And I think we'll look at this. We know that COPD is a down spiraling disease without question. Whether you treat COPD or whether you don't treat COPD, you're going down the drain. Whether you look at FEV1, whether you look at lung function, whether you look at patient scores, whether you look at dynamic indices like 6-minute walk distance, you're going down the drain. And your basic intent, I think, would be to try and prevent this going down the drain, or at least slow down this going down the drain. I think this has already been said. And we understand that these are the causes of COPD that you're looking at us. We've always looked at smoking as the cause of COPD. If you take the West, for example, smoking equal to COPD, COPD equal to smoking. That's it. They have absolutely nothing else at all. So all the data that we've got so far from the West has been smoking related. And I think that's the one that really differentiates Western COPD from Indian COPD, because we are very different. We have pollution, we have occupational exposure, we have biomass fuel exposure. The current scenario would be that it's definitely going up from 1971 to now, and I think from 6.45 to 14.84. And we have multiple varieties of smoking. We are always excellent at innovating things, and I think we've been innovating this from the time of Akbar, maybe, because Akbar was the one who really started using the hookah. And I think it's important for us to understand that smoking is sort of inbuilt into the history of India. You look at the Mughals, for example, they were all great hookah smokers, Aurangzeb and all those people. And I think it's important for us to realize that there's a diversity in what you're looking at. But what are the effects that you're looking at? I think this is quite interesting in the sense that you're not looking at one entity, but you're looking at multiple entities that are growing around it. And I think that's the key here. The key is that COPD is not a lung disease, but it is a systemic disease. And I think therein lies the problem, and therein lies the complexity, not only of diagnosis, but also of therapy. And we fully understand, and we fully understand that this is a very complex equation with multiple facets and multiple segments around it. And I think we'll just go into this. The cost, of course, we've always known that there is a cost. Nothing in India comes free of charge, except the rain maybe occasionally, and the sun is always shining. But that's the only thing we get without a cost. For everything else we pay, including the water that we drink. So I think there is an economic burden. But the most important thing is that 90% of our COPDs are walking around free. They are not diagnosed. And I think that's one of those things that we really need to understand. The identification of patients with COPD who are so far unidentified and walking around scot-free, I think is a responsibility for all of us. There are triggers, there are effects, there is systemic inflammation, exacerbations, bronchoconstriction, expiratory flow limitation, dynamic hyperinflation. If you look at two things for me, which are very important, I would think that the things that are important are, number one, there is chronic inflammation, and this inflammation is not only pulmonary, but also systemic. And this causes the hyperinflation, which I think is the most important pathophysiologic entity that you have in patients with COPD. It is the cornerstone of all the symptoms that are built in around it, be it a carbon dioxide buildup or be it an oxygen deprivation. I think hyperinflation is key. And what really drives the hyperinflation is the repeated circular cycle of exacerbations that we're having. So I think we need to consider three entities today. We look at systemic inflammation, pulmonary inflammation, systemic inflammation, one vertical. The next vertical, of course, would be hyperinflation. And the final vertical, of course, would be the exacerbation that drives this through. And I think this is something that is known to all of us. And I don't honestly think we'd look at it. And look at the number of systems that you're going to be involved, right from anxiety, depression. You call in the psychiatrist and you call in just about any specialist, he'll have some role to play in this. Now, let us understand that this is this so-called trapped air that we're looking at. And I think sometimes our patients fail to understand what this trapped air means. One of the things I often tell them is that if you take in 100 ml of air, for example, with every single breath, 10 ml of that remains in the lung. You expire only 90 ml. and 10 ml remains in the lung. And this keeps getting accumulated with every single breath that you take. And you finally have this extremely pathophysiological phenomenon of air trapping with hyperinflated lungs, as we shall see. So there are a lot of people around the world who are going. And of course, smoking is the most important cause of COPD, has been the most important cause. And in the West is probably the only cause of COPD. And I don't think there's any doctor who has not seen this Fletcher and Peto curve that we're really looking at. The essence of this curve, I think, is just one single point. It is never, never, ever, ever, ever too late to stop smoking. And if there's one message that needs to go from here, as far as smoking is concerned, is that it's not the age where you quit. It's the question of whether you quit at all in the first place, and the sooner you quit, the better. And I think that's what is important. So a major health problem and the consensus, of course, the gold guidelines were formed. We understand that obstructive airway disease are extremely common and they're growing by the dozen in India. Now today with this sort of added pollution, when you take a place like Delhi, for example, you really have a huge sequence of problems. Now it is spread all over the country, and I think that is really what is important. Of course, you have places like Delhi and Chandigarh, which probably have a slight increase, but I think it's a very common general phenomenon all over the country. And that's really what is important. So disease patients in India, am I going front or am I going back? So the impact of exacerbations. Now we talked about this third vertical of exacerbations. You'll find that every COPD who exacerbates and exacerbates quickly does have an increase in mortality, be it gold 3 or gold 4 or whatever stage you want to call it. And I think it's important for us to realize that exacerbations are a key in this sort of thing. The ticking clock is exacerbation without question. Exacerbation further increases hyperinflation. Hyperinflation further increases exacerbation. And it's a vicious cycle that we need to break as such. Now, we really started with the ICS-LABA when we started patients with COPD, but those were the days where we used ICS-LABA more by default than by intent. And I think that's really what we are coming to. You have the inhaled corticosteroid and the long-acting bronchodilator that have been used for a very, very long time. And today it is almost a habit of the pen for many doctors to prescribe ICS-LABA in these patients. Use of ICS remains controversial because there is no real large volume evidence to really look at it. If you look at major guidelines, they will tell you that the relationship is like this. It is a sort of clandestine relationship that occurs behind the long-acting muscarinic antagonist. And I think this is really what we are looking at. So the ICS is controversial. We'll talk about the ICS a little later, but we clearly need to understand that we do not prescribe ICS-LABA by default or by intent. I think we prefer more to prescribe by default rather than intent. And I think we should be very careful about this as we see. Is non-smoking COPD in India a reality? I think this is something which is extremely important. It is not just Western literature getting transported to India. The population attribution is about 40%, more than 40 to 60% of our patients with COPD are non-smokers or never smokers for that matter. Patients who are occupationally exposed, and I think non-smoking risk factors, treated pulmonary tuberculosis, we look at that outdoor air pollution, low socioeconomic status, occupational exposure, and I think you just name it and you have it. But I think this is really what it's all about. This post-TB COPD is so very common for us. We've seen millions and millions of these patients coming on and on and on, and these go into multiple exacerbations, multiple infective exacerbations, finally end up with bronchiectasis and then empyema and all sorts of complications you're looking at. So post-TB COPD is an established entity in a country like India, without question. Chronic asthma is a risk factor of COPD. And I think this is again very important. The more and more remodeling that you get in asthma, the more and more poorly that you treat an asthmatic, the more and more ability or possibility he has from moving to an asthma to a COPD, which means his reversibility starts decreasing. Asthma is reversible, COPD is not reversible. And I think this journey from reversibility to non-reversibility will really be the impact of what we call airway remodeling that we have in these patients. And I think this is really what we're looking at. Biomass fuel in rural India, in urban India, and I think it's just across the board, and it's definitely more in rural India than urban India. Pollution is something that is less said the better, because I think we know that the air that we breathe is not as pure as it needs to be it the PM 2.5 or the PM10. It doesn't really make a difference at all. We are breathing bad air without question. And I think that's one of the better things that happened during this lockdown with COVID. We found that the air quality was becoming better in a lot of places. So I think it's important. And of course, occupational pollution. We have multiple occupational pollutions, like this bricklaying, brick kiln industry for that matter. Significant increase in these patients who are involved in mining, especially with granite mining and things like that. I think that's again an occupational. Non-smoking COPD, non-smokers, never smokers. And I think this is something that we need to understand. And I think if you take a 45-year-old woman who comes to you with little shortness of breath, she's obviously a little overweight. She's probably about 60 to 65 kg. You will ask her to blow on the spirometry. She has a reversibility of under 12%. You probably have to brand her as COPD, but you don't know what type of phenotype of COPD she is. She has no exposure. She's probably had some biomass exposure in childhood, probably continues to have the biomass exposure. So I think the question of looking at biomass is very, very important in these patients. More than 80% of homes in China, India, and Africa continue to use biomass, and biomass attributes to more than 50% of deaths from COPD, 75% of which are in women. So I think the question of female COPD is almost equal to biomass COPD. And I think this is something that we need to understand. This equation is almost as static and as persistent as the Western smoking COPD and the COPD smoking that goes behind it. So biomass, of course, is Southeast Asia without question, large parts of Africa, again, without question. And we understand that biomass leads to higher concentration of particle size, PM10 and PM2.5, mean concentration of 30 to 3,000 micrograms of PM10 in a 24-hour working day. Standards of WHO, of course, are 150. You look at Delhi for that matter, and you look at the air quality in Delhi, it's probably 30 times, 40 times the acceptable WHO level. And I think we need to understand that. Women in developing countries, young children, again, it's important. This woman lives in a hut with no ventilation whatsoever. All her entities are done inside that small hut. The living and the washing and the sleeping and whatever goes on in the house is in that 50 to 60 square feet that she has, and she probably has a very, very small air vent. So I think it is important that these patients spend the majority of their life inhaling unhealthy smoke and smoke-related products. And I think with comparison to tobacco smoke, and I think we need to make a comparison with that. So COPD smokers with COPD non-smokers. Non-smokers with COPD has less impairment of airflow limitation, gas exchange, lower prevalence of emphysema, chronic cough and sputum compared to their smoking counterparts. Tobacco cessation is warranted in smokers. And I think there will be a lot of people who will contest this statement. And this is put out purely for the sake of the sort of contest that you probably could have to this. So COPD in never smokers we talked about, is it a different phenotype? And I think that's something that we need to understand. As I told you, we have this 45-year-old man who comes to you with 10% reversibility or 8% reversibility. What is he? Is he COPD? Is he asthma? He has absolutely no previous history whatsoever. And we understand that it's going to be very, very difficult to place your finger on this as such. So non-smoking COPD differs from COPD. Similar lung deterioration, whether it's tobacco smoke or biomass. But again, the lung morphology of COPD patients exposed to tobacco, they have more emphysema, more epithelial damage, whereas biomass COPD patients probably have more fibrosis, more pigment deposition, and thicker pulmonary arterial intimal concentration. So you have a biomass COPD and a tobacco smoke COPD, which is the smoking and the non-smoking COPD that we're looking at. Of course, there are huge gaps in healthcare delivery, and I think it's very important. I was listening with great interest to the previous discussion that was going on, though I couldn't follow much, but I think there's so much of social awareness and social consciousness in your society that I can only be jealous of people like you, honestly. I wish in our state we were as socially conscious as you are. We are not. I'd be the first person to accept that. And I only hope and pray that this sort of social consciousness will continue to grow in the days to come. So comorbid conditions, coronary artery disease, lung cancer, cachexia, skeletal muscle weakness. There are a lot of compliance issues, especially in rural patients with inhalers. There are myths about inhalers, difficulty in obtaining inhalers, cost. All these things are important entities that we're really looking at in these patients. So what are your treatment options? Bronchodilators, anti-inflammatory agents, where we've already said more out of default than intent. Preventive measures. You have non-pharmacological therapies like using oxygen, using NIV, pulmonary rehab and things like that. So I think it's important to look at this. Look at the gold. And I think this is an important thing that we are looking at just to make this assessment of ABC, ABC and D. And you look at the number of exacerbations. What the gold has really taught us is that do not rely only on the pulmonary function when you treat a patient long-term with COPD. And I think that's very, very good. Use the pulmonary function to make a diagnosis. And once you make a diagnosis, whether you want to move from A to B or B to C or C to D, use different indices as such. Use exacerbation as an index. Use patient scores as an index. Do not depend on spirometry, because the older and older you grow, the more and more comorbid conditions you acquire, and the more and more irrelevant your FEV1 by FVC does become. And I think all of us remember the pink puffer and the blue bloater that we saw third year in medical college. And I think it's important for us to realize that. So this is, of course, the gold, the 2020 gold. You diagnose, of course, with spirometry or adjust pharmacotherapy, non-pharmacological therapy. Initial assessment, look at the gold, as I said, then look at review, initial management and symptoms. And of course, group A would be bronchodilator, group C. And I think this is a question that we will try and address when we discuss these things. The fact does remain that the LABA-LAMA today is probably the best in patients who smoke. I think that's a question that is absolutely non-negotiable whatsoever. We fully understand that with the so-called FLAME trial that we had some years ago, the LABA-LAMA is the key there. Now, what we're going to do in non-smoking COPD is something that we will talk about a little later on. So review, assess, and do this constantly and continuously. And as I told you, dyspnea, which is a direct proportionate to hyperinflation, and look at exacerbations, which again are related to hyperinflation. And ultimately, you'll find that the key pathophysiological entity that you have in COPD is dyspnea and hyperinflation. And you look at A, B, C, and D, look at dyspnea and exacerbations. And I think it is very, very important that we give patients some ordered methodology of taking medication, especially the rescue medication. Give them advice about diet, give them advice about walking, rehabilitation. You can't expect every single patient of COPD of ours to go to a rehabilitation center. That is not physically viable in a country like India. So I think we need to be very careful about that. So the evidence of triple therapy, and I think we just need to touch on the fact that we're moving from dual therapy towards triple therapy, which means that we're using an ICS and we're using a LABA and a LAMA. And I think this is something that, I'm sorry, we are using an ICS and we're using a long-acting beta agonist and antimuscarinic agent. These are the various trials: single inhaler versus triple therapy, the so-called triology trial. Definite benefits in increase of prevention of moderate to severe exacerbations versus BDP and fluticasone. Then we have the Trinity, again, a triple drug therapy trial, which improves pulmonary function in these patients. And I think the one thing that Gold of 2020 tells us, you have a preferred treatment, you have a preferred patient phenotype, and you have a patient preference, which are what are the patient's common beliefs, requests, and I think it's important. We today consider definitely indicator-like pyronium to be the LABA-LAMA of choice, very closely contested with by formoterol and glycopyronium. I just wanted to put this up because we could have some discussion at the end of it all. I'll just finish over the next 2 minutes with this thing. Tobacco, we will stop with smoking cessation because there is no talk on COPD that should be away from smoking cessation. And I think that's important. Now, this is the cigarette epidemic. And I think we are in the midst of a pandemic, which has lasted for about 8 to 9 months. And this is a cigarette epidemic, which has lived from the time of Genghis Khan and Aurangzeb. And I think we understand that it keeps going on and on and on. It's a cycle that never stops. And of course, half our patients are passive smokers who smoke out of the box. Then nicotine dependence, of course, we know is a clear disease, is not a habit. And these are the guys who keep perpetuating nicotine dependence one way or to the other. And I think these people are definitely responsible for grooming of youngsters, for trying to mold youngsters. And I think it's important that we realize this. The nicotine patch is an important entity in this. It could be a clear additive to medication. And I think this is the drug that we're really looking at, which we had good success with. Varenicline, which is a nicotine acetylcholine receptor antagonist. But the most important thing that we need to understand that it's not a full antagonist, it is a partial antagonist. This is a full antagonist, which means it takes off all the neurobiologics that are present, both the dopamine and the other neurobiologics, which means that if you knock the receptor off, you have craving, which is present. And I think it's very, very important for us to understand that. So I think we want a partial receptor, which leaves a bit of the neurobiological still there, which means the craving is addressed. And that's what you get in these patients. When you hit from above, there is a blocks reinforcement, and at the same time, there is a definite craving withdrawal and relief. So you have a partial agonist, which is varenicline, which is the reason why it is much better than the previous drug called bupropion, which was a total agonist where you knocked off all the neurochemicals once and for all. So it's a major COPD problem. Underutilization of spirometry, increasing recognition of systemic inflammation and comorbidities. And I think the future will offer some strokes forward. The way forward, of course, would be counseling, smoking cessation, exercise, and pulmonary rehab. And I think this is very important. How do we talk to our patients with COPD? And I think, do we laugh at them, or do we smile at them? Do we listen to them at all in the first place? It takes me more than 3 weeks to prepare a good impromptu speech. We have 2 ears and 1 mouth, so that we can hear twice as much as we speak. Courage is what it takes to stand up and speak. Courage is also what it takes to sit down and listen. And I think really pearls of wisdom. I think we not only need to talk to patients, but we also need to listen to patients. And that's where I think most of us make mistakes, as we see. To see smoking is the easiest thing I ever did. I ought to know because I've done it 1,000 times. Less famously, he was known to say, it has always been my rule never to smoke when asleep and never to refrain when awake. And I think it was a war between the cardiologist and the pulmonologist to get to Mark Twain. And finally, he died of cardiovascular disease. I'm not much of a mathematician, said the cigarette, but I can add to a man's nervous trouble, subtract from his physical energy, multiply his aches and pains, divide his mental power, and take interest from his work and discount his chances for success. Is it true that you smoke 8 to 10 cigars a day? Is it true that you drink 5 martinis a day? It's true that you still surround yourself with beautiful young women. That's true. What does your doctor say about all of this? My doctor is dead. Ladies and gentlemen, I think this is really what our patients will be telling us after we are gone. My doctor was not conscious enough to tell me that smoking is bad and smoking has to be stopped. And that honest and that responsibility lies with us. So finally, we are looking at the 4th APs, the sum of the first 3, sees nobody, hears nobody, and speaks to nobody. If the first monkey here is the ICS LABA, the second monkey here would be to add the triple drug to this. You add the long-acting beta agonist, and then the third would be this triple drug that we've really looked at today. But please remember the 4th ape. 2 years from now, we'll probably be talking about a quadruple therapy, and that probably will include everything, including salt and pepper, for that matter. So I think we are evolving, but I don't know if by evolving we are improving. I really doubt the fact as to whether evolving is equal to improvement. I'm not quite so sure, and I think we need to know that there are distinct entities in COPD that we need to address. And unless we address these 2 entities separately, it is going to be very difficult. So finally, is it a wolf or is it a dog? I think this is something that we need to realize. We also need to understand that a great relationship is about two things. First, find out the similarities, and second, respect the differences. Thank you very much for the patient listening.
Thank you, sir. Thank you, PK Thomas, sir, for that wonderful insight into the COPD and going deep into the Indian scenario of COPD. Thank you for that wonderful speech. I now request Dr. Judo, sir, President of APT, to kindly take over. Judo,
Okay.
sir. Yeah.
So I think it was a very, yeah. Can you hear me? Yeah.
Yeah, sir. Please continue. Please continue, sir. Yeah.
Oh, okay. Thomas sir, it was very simple and I think well taken up. Okay, so I think we'll have some panel discussion on a few of the things which I think recent advances in COPD. We have an esteemed panelist with us. So after the panel discussion, panel opinion, I think Thomas sir also can join that. And then questions can be asked. Then even some questions can be put in the chat box also, if somebody is willing to do that. So I think we'll start the ball rolling with Davis Paul sir. Sir, the first question, not the question actually, your opinion actually on, there are a lot of comorbidities we have with COPD, including pulmonary artery hypertension and other comorbidities. And I think what's new, like in the management of these comorbidities, or what anything, because COPD is fast advancing, and so I think we'll have a lot of new things coming up in COPD. So what's new in the comorbidities, especially in comorbidities of COPD? Yes, Paul, sir.
Am I audible?
Yes, sir, you are.
Yes, sir. Yes, sir.
Yes, sir.
Okay. So good evening.
Kindly switch on your
First of all,
video, sir.
Thank you very much for inviting me as a panelist. And Thomas sir, it was a wonderful session. I really appreciate your slides, wonderful slides. About COPD, the problem is COPD is one of the most neglected diseases. So even though we talk a lot about COPD, it is not really appreciated by all. The public doesn't know much about COPD. That is an issue. It is primarily an inflammatory disease of the lung or airways, but the inflammatory mediator spills over to the systemic circulation. That was the concept that was there previously and causes a lot of systemic manifestations, like as previously mentioned, the weight loss is one of the osteoporosis, the diabetes mellitus, hypertension, coronary artery disease, cerebrovascular accidents, the anxiety, depression associated. These are some of the systemic effects of the COPD. And the concept is, once the COPD sets in, even though we can treat it, it goes on. So it is always better to prevent. The focus should be on the prevention of the disease, not once the disease sets in, it goes on like that. And one of the concepts that has been recently introduced is it has got a genetic component also. The from birth itself, when they are exposed to inflammatory infections, when they're exposed to smoke, all this can later lead to COPD. So it's very important to identify the disease in early stage. What are the factors that causes it, and prevent it. Prevention is a better strategy. Once it sets, its only thing is we can do is to start some symptomatic management. Of course, the quality of life has significantly changed with the newer bronchodilators and the rehabilitation, etc. The vaccines also has done a beautiful job, especially the influenza vaccines. Many patients takes it, and one that is extremely useful to control the recurrent exacerbations that are commonly associated with COPD. Over to you, Jodo.
Okay. So I think we will go ahead with the next question. Dr. Ennis, am I audible?
Yes, Dr. Judo.
Okay. So there are a lot of recent advances happening in
Sir,
the
please
treatment of
switch on your
COPD.
video.
So a lot of recent advances in the COPD management part. And we know that even intervention part, there are a lot of new things coming up. So I think, can you just highlight on a few things which is upcoming or at present it is there, so that it will be beneficial for the COPD patients? Renisa.
Yeah. Warm good evening. Am I audible, Dr. Judo?
Yes.
Yeah. First of all, let me thank the IMA Club Thrissur and my friend Judo and Unni for inviting us for the panelist discussion on COPD. When I was going through the number of participants, I was really astonished to see all these 40, 50 participants. But I can't make out because there are a lot of Moto Gs, a lot of Galaxies, a lot of Redmis. But still, and a lot of numbers. So still 4 numbers. So still, what I make out is 50% is around physicians. Am I right, Dr. Judo?
Yes,
I think so.
yes, correct.
So my talk, my discussion on other new concepts about the COPD. What's new in 2021? For the COPD, our Bible is the GOLD, Global Initiative for Obstructive Lung Diseases. So that has been there since 2002, and we are following the updates or the changes what they make yearly. And what the 2021 project for the the general physicians, starting from the definition, there's no much change in definition, but they are giving more priority for research on the biomass related COPDs. As well as they have recognized European population, they have recognized few of alpha antitrypsin PI-Z genotypes around 0.12%, which needs some augmentation therapy of alpha-1 antitrypsin. About diagnosis, Dr. P.K. Thomas, sir, I really loved the slides which he has projected. Even the romantic ones with LABA, LAMA, and ICS. For the diagnosis, it remains the same for the assessment of airflow limitation. That's our the sixth vital sign, or our own spirometry to know the amount of airflow limitation. But the change is you have to look into the symptomatic profile of that patient and about the exacerbations in an year or the hospitalizations in an year. That gives the overall which group they belong to, A, B, C, D, which P.K. Thomas sir was projecting out. So once you know your patient, you can give a lot of support, you can prevent, and you can have some maintenance therapy. So what the the GOLD is projecting about the e-cigarettes. I'm talking about only the new things, right? The effectiveness of the safety of e-cigarettes as a smoking cessation aid is uncertain. So what we have to do is whatever the P.K. Thomas has told, we have to go ahead with the nicogums or nicotine gums or nicotine replacement therapy or vernaculine. Okay, or some antidepressants which you may aid the smoking cessation. Then again, about vaccination, they still say yearly influenza vaccine and 5-year pneumococcal vaccines. But what recommends right now an add-on is a Tdap vaccination for adults with a COPD. That is to prevent the protect against the whooping cough, the pertussis. And then coming to the therapy part, the pharmacotherapy of the stable COPD, the LABA-LAMA always long-acting beta-2 agonist and long-acting muscarinic agents, as you all know, it's still prevalent. The LABAs, the old and gold, our salmeterol, then the formoterol. Right now, what we get is the right now in the market is bilandrol and indacaterol. They are the new add-ons to the LABAs. And then the LAMAs, long-acting anti-muscarinic agents. We were having tiotropium, but now the add-ons are coming with the glycopyrronium, umeclidinium, eclidinium, and all are in the. I mean I think the umeclidinium is in the right now in the market. Glycopyrronium already in the market for the last 2-3 years. So they are the add-on LAMAs which we can choose. And then about the ICS, we have mometasone, cyclosonide, which are the add-ons to our old beclomethasone or budesonide or our good and old fluticasone. So what they say is a triple therapy. We can reduce some mortality, and there is some reduction with the what you call the exacerbations and the hospitalizations when you add this ICS or inhaled corticosteroids to a LABA combination. So that's the few studies have come up like ethos, impact. Then P.K. Thomas was projecting about another study. There are a lot of studies, but ultimately what they say is you add on ICS, especially if you see some eosinophilic component in it. Like if the blood eosinophilia, you see more than 300 cells per microliter, they may show some reversibility, or there can be some asthmatic component in those COPDs, maybe an overlap of asthma or COPD and COPD. And then about the inhaled corticosteroids, same, both the current and ex-smoker benefit from ICS use in terms of lung functions and the exacerbation rates. And the heavy or current smokers do not have the same benefit on lung function from ICS. And only thing is you have to see for any infections getting more with your ICS, or whether there is some admissions with the pneumonias, then you have to be careful about your overuse of ICS in moderate to severe COPD. Otherwise, the patient can get stable on LABA-LAMA combination itself. About methylxanthines, there is a new addition of, you have, once you give the Derflin stuff, you have to be careful about the interactions between the other drugs, which the patient is concurrently getting for the other comorbid situations, as Dr. Davis Polser was mentioning about. They may be on some antibiotics like erythromycin or ciprofloxacin or allopurinol or cimetidine or fluoxamine, all have some interactions with our theophylline or the methylxanthines. The new addition is the roflumilast, which is a PDE4 inhibitor, right now available with a few companies. So that also gives good benefit for as an anti-inflammatory cover. About mucolytic antioxidants, the edrosterine have a significant effect, and you can use even N-acetylcysteine, NAC. Then about the gold, talking about beta blockers, there is no evidence that beta blockers should be used in COPD. If they are getting it for some cardiac conditions, well and good. Otherwise, they don't prevent any exacerbations. That's what they conclude. I don't know, the Europeans might have used it for the control of exacerbations, but that's not of use. Then they include some the new things which have been included in the new gold. Is I was surprised to see acupuncture or acupressure, which may improve the breathlessness in advanced COPD. I have to read about that. It's an alternative medicine. I don't know about in the current era. And then about the self-management protocols, the ventilatory supports, the NIV has shown in a stable COPD will reduce the risk of mortality as well as the risk of hospitalizations. Then pulmonary rehab, it's getting a very high value, especially as a club, a mob kind of physiological benefit or the psychological benefit is there for the patients. And also about high flow oxygen therapy supplementation in COPD patients during the pulmonary rehab or during exercise training is getting importance. That's what the gold say in 2021. And then about the physical activity, they have shown some pedometer based physical activity interventions, then the community based physical activities and coaching interventions, which will prove some improvement in their overall lung function. And about PR in a COVID era, they still maintain our SMS or social distancing or sometimes mask and the hand hygienes. And the home-based programs have been devised with remote supervision. So that's all about the common things which has gone. Which has got some newer interventions. Otherwise, everything was well mentioned by the previous speakers. For the pulmonologist, I do have some 7 breakthroughs in the medical field of pulmonology for the COPD therapy. One is seven breakthroughs. One is our stem cell therapy, which may have some future. That's called the regenerative medicine, which will generate some healthy cells in the body and replace the diseased ones. So that may prove benefit in a lot of, not only in COPD, some kind of macular degeneration, spinal cord diseases, injuries, stroke, heart diseases, and more. It's yet to evolve. That's the first one. The second one is endobronchial valves, which we right now are getting trained from European countries or US. We can put some the single valve mechanism that we can reduce by installing these devices, endobronchial valves, which will allow only the air to go out from a trapped lung, and it won't allow the air to enter in. There are a lot of sapphire valves or the umbrella-like valves, which will give only the air to go out, not and it prevents the entry. That reduces the hyperinflation and keeps the good lung in a good condition. That's the second part. And once we get the FDA approval, we will start deploying this interbronchial valves. And then the third part is the targeted lung denervation. That's also a bronchoscopical procedure. A catheter-induced RF emits the RF radio frequency ablation of some nerves, and then they interrupt the transmissions, which is conducted through acetylcholine. So we have to, read about the procedure, or we can go ahead in the future. I think that about targeted lung denervation. Especially if it's the airway inflammation is too high. Then about BTVA or our bronchoscopy thermal vapor ablation that has come into the few of our near states like Coimbatore and all. They do ablate the hyperinflated lung or emphysematous lung, especially the upper lobe emphysema. They ablate with vapor, and the upper lobe predominant emphysema can be removed or can be get fibrosed, and then that improves the lung function, exercise capacity, and quality of life. And then the bronchial rheoplasty has been studied, where the mucus is a serious problem for the COPD patients. And for the chronic inflammation, or due to the chronic inflammation, the whatever the mucus glands can be noted off by bronchial rheoplasty or rhinoplasty procedures. Then, as you all know, the robotic lung volume reduction surgeries, or LVRS, is getting more and more invested side. They reduce the lung, deformed lung, and get the more functional lung into position, as well as the lung transplants. So that also will have some future for COPD. And right now for asthma, you might have seen the interleukin-5 antagonists have come up, like Nucala or Mepolizumab or Benralizumab. These all biologicals have been tried in eosinophilic predominant COPD patients, or wherever there is an asthma COPD overlap. And but they say 1/3 of COPD patients are of this phenotype, and they really do well with the biologicals. So that's to conclude, what I mean to say is in the future it will be more and more individualized care and a specialized treatment for COPD from the pulmonology side. That's what I want to conclude. Thank you very much for patience.
Yeah. Okay, Dr. Renis, I think it has been well covered. I think most of the new things and a lot of new advancements in COPD treatment. Before going to Murali sir, just one question to Thomas sir. Like, what exactly in the past 1 year had made the COPD patients a dramatic change? Like, what is the recent advance, either in the treatment strategy or whatever? What one or two molecules or one or two things can you mention?
Well, I think if in asthma, you ask me, in the 2000s, it was the ICS LABA which really tilted this in favor of the asthma. And I think the LABA-LAMA and the FLAME is a sort of landmark trial that really points in a certain direction. But we also need to understand that there is more to this and than just the FLAME and the smoking COPD. They are different. We have a different phenotype. We have a different outlook. You cannot transpose the Western pathophysiology into smoking COPD, into non-smoking COPD and biomass COPD. I'm sure there are huge lot of differences between this. And I think that's where I think we need to get to work there. Not only try and prevent the biomass in the first place, but also look at the people, because we're going to have, even if you're going to prevent this biomass, maybe by the next 15 or 20 years, all these people who are there today are going to progress to 50 to 60. You're going to have this at least for another 30, 40 years without question. So I think we need to prepare for that. And I think that is again very important. So ICS LABA for asthma and LABA-LAMA for COPD, I think would be the landmarks, is what I can say. I'm not a great fan of this triple drug therapy, because I think the triple drug means that you use a one shirt fits all phenomenon, which I don't honestly agree with. And I think the question of trying to individualize therapy, I think, becomes important. Yes.
Correct, sir. Sir, there's one question from the audience that you mentioned about the coils, mosquito coils causing COPD. Now, what about the plug-in newer good night and all those things, liquids? Is there any harm using that? Like, is there any studies with that or something like that?
No, the whole point really is to really understand what is worse and what is worst. And I think these are the two things that we're really looking at. We're looking at a relatively negative phenomenon where one is probably more severe than the other, and one probably is slightly lesser than the other as far as the ill effects are concerned. But I think both are bad. A thief is a thief, whether he steals 10 paise or whether he steals $10,000. There's no issue at all there behind it. So I think they're all bad without question. Maybe if you want to be a real optimist, you can sort of argue and say this is probably better than that. But I think that'll be more for the sake of argument.
Correct. So I think maybe to repel the mosquito, maybe we can use that. It depends on the need. Okay, so I'll go to Murali sir. So now it's COVID time, and I think he's a COVID warrior from medical college. I think battling COVID, the first COVID in India. So Murali sir, what is COPD and COVID? Are we worried, really?
Screen sharing.
Thank you. Good evening.
Screen sharing disable. എല്ലാവരെയും കാണാം.
Good evening, sir.
Hello.
Please go ahead. Sir, yes,
Okay.
sir. Yes, sir. You are audible, sir. Please. Yes, sir.
Oh, good evening. Thank you, Dr. Jodo, Dr. Unni, IMA, APT for the opportunity. And I a big thanks to PK Thomas sir for the wonderful presentation. Now the question is, COVID in COPD, are we worried? Definitely, a straightforward, big yes. Yes, we are worried. Why are we worried about these things? So what is the impact of COVID in COPD? So we know that in the lockdown period, the patient suffered a lot, especially the COPD patients. So for that matter, any patients with chronic illness, diabetes, hypertension, coronary artery disease, and COPD patients suffered a lot due to inaccessibility of the medical care. And also, they might have exhausted their medical supplies, especially the inhalers which they are using. And also the anxiety and depression associated with the uncertainty of the lockdown and the economic recession associated with lockdown, and so on and so forth. So definitely, they had a very bad time during the lockdown period. Later, we gradually opened up the lockdown, and the COPD patients exposed to the community, they might have affected with the COVID-19, and the exact data we do not have. And our common sense tells that when we unlock the situation, then they will be exposed to more number of COVID-19 infection. And why we think that the COVID patients are at a higher risk of COVID complications? So as we know that the COVID virus or SARS-CoV-2 virus affects the ACE receptors or aldosterone converting enzyme receptors, and in patients with COPD, these receptors are upregulated. So it is possible that the number of viruses attaching into the receptors will be more. So this will allow a more entry of more number of viruses into the system of COPD patients. Moreover, current smokers and recent quitters of smoking can have the same effect of upregulated ACE receptors. So they also are at a higher risk of contracting the infection. However, we don't have any definite data from India, but the data from the China, United States, and United Kingdom are conflicting, because just because the study design was not proper, their sampling was not proper, their methodology also was not proper. There was an apparent increase in the number of COPD patients from some studies, but many of the studies underplays the importance of COPD in the intensive care settings. Maybe there are a lot of issues when the pandemic was there in the West. Like they might have selected patients with younger patients without much comorbidity, with a good result, or that may be one of the reasons when the resources were poor. We don't know exactly what has happened. And many of the patients with COPD might have experienced an exacerbation in between, a milder exacerbation. Theoretically, a milder exacerbation like SARS-CoV or COVID-19 can change the course of the medication which he is on. So we can call it as an exacerbation. So some patients might have had the COVID-19, which we may not be able to identify because many of the patients are homebound. And some patients in the hospital, they are on the CPAP or the high flow nasal oxygen. And from the many studies, it is seen that the number of admission to the intensive care setting is a bit high compared to the non-COVID and non-COPD patients with COVID. And many countries might be selecting younger patients over the COPD patients for ICU admissions. So those data are conflicting. And from our own study, we had a maybe 500 odd deaths in our hospital. When we audited those deaths, we know that COPD as a comorbidity, the number was very, very less. So apparently there is a less number of COPD patients in the ICU, but those who had COPD as a comorbidity, they had the chronic kidney disease or the coronary artery disease as a major comorbidity. So that may be the major or the leading cause of death in many of the COVID patients. Initially, we had apprehensions on using the inhaled corticosteroids and nebulizers. But later, the GOLD guidelines as well as the WHO came forward with advisories for the use of these inhaled corticosteroids and nebulizers. Anyway, the current data suggests that there is a higher odds for hospitalization and intensive care unit admissions in patients with COPD and COVID together. And we do not have any markers for, as in other patients, we don't have any markers in whom the ERDS will set in. We do not know that. But definitely, if there are some complications like COVID pneumonia, definitely COPD patients, our common sense prompt us to believe that this COVID pneumonia can make the COPD patient worse. So that's what from my side. Thank you.
Thank you, Murali sir. I think Chennai had witnessed more number of cases than Kerala has witnessed. I think so. And I think now it is coming down. So Thomas sir, what is your take on this COPD and COVID? Like anything you can specify?
No, obviously, any lung disease is going to be exaggerated. And COPD being a constant bronchial colonizer for that matter, I think infections are the key. And we lost many, many patients to infection only. It was a question of ARDS and sepsis. And that's really the bottom line, as we can see. But I think what I think is that patients who have treated themselves properly, be it asthma or be it COPD, definitely were not as bad as what we thought they would. In January, I thought my asthma and my COPD patients are going for a 6. Right? They get the virus and then nothing can save them. But I think I'm wrong. I think that much I will be able to accept and say that I have been wrong on that. And most of these patients have done fairly well, I should say. That's really what I would really look at as such. But definitely in patients who started crashing, if they had associated COPD, they definitely did worse. There's no question about it. Like Sir said, if they had additional comorbidities like CKD and diabetes and things like that, I think it did make them worse without question. But I think the fact that sepsis was the whole background on which the whole platform was built, I would certainly think a patient with COPD needs to be very conscious and aware of trying to treat himself optimally, make sure that he gets the best precaution, gets the best prevention, and then takes the best actions to make sure that he really doesn't get into the viral infection.
Okay, sir. Sir, there are some studies, maybe studies or some reports saying that ICS use in these asthma and COPD patients is preventive or protective for the lungs. Is it true, or like is it a?
There is a city in India which I will not name, which swears by this drug called cyclosinide. In post-COVID patients, you have post-COVID fibrosis and they swear with cyclosinide. So there's no real data for that, as we shall see, but then a lot of them are very convinced that it does something good. But I'm not very sure, and I'd be very, very skeptical, because I would be very skeptical about using this this ICS as such, unless there is a definite background of either asthma or COPD, or they've been on the same drug before they got the COVID rather than after the COVID. And about cyclosinide, honestly, I have no experience at all. But I would really like to learn over a period of time as to whether there is something behind that at all.
Okay, sir. So I think we had almost finished our panel discussion, and now the questions, I think it is open for discussion. If anybody want to ask some questions, they can ask. Unni, anything to say? Principal sir, anything to be added?
I have put one question in the chat box. Do you
Yes.
recommend the use of air filters for COPD patients, at least in their personal room?
There's nothing wrong, absolutely nothing wrong, but no real evidence. But then it's absolutely harmless to use it. And I think it's fine. Patient wants to use, he can use, but I won't ask patients to use the air filter. No.
The PM counters are useful. Particulate matter counter.
Particulate matter counters are useful, but I think, but what is it really going to tell you? The best thing in all these atmospheric pollution in Delhi, for example, best thing is stay at home. Like the best thing with COVID is to stay at home. That's really what this is all about. So I think the question of avoidance, I think, is what is really very important. That elders and patients with COPD preferably don't go out as much as they do or as much as they want, but try and stay indoors as such. And that's really what I would add. What else can you do about the pollution? I can't really think you and I can do anything about the pollution.
Hello, Judo sir, can you hear me? Hello.
Yeah. Can I make a comment?
Yes.
Yeah.
Nowadays, we have discussed about the COVID-19. Now, in the future, we may have to equip with. We have to be equipped with. To screen patients with the post-COVID ailments, especially the respiratory ailments. Both it can act as a trigger of asthma, and it can cause bronchiolitis. It can cause fibrosis later on. We don't have any markers to predict these fibrosis and all, but I think we may have to prepare a questionnaire to know which patient is to be screened for these sort of complications later on. So even without any respiratory symptoms, patient who had COVID-19, now they are coming with respiratory, involvement in the form of wheezing, recent onset wheezing, as well as features of bronchiolitis, and bronchiolitis obliterans with organized pneumonia, and later on with fibrosis. So these things has to be positively looked for in the future. That's the one suggestion I can give.
COVID, it is mainly endotheliitis. That is why patients with COPD and asthma are not that much affected, and they are on steroids. That may be one reason. It's mainly the endotheliitis that is more important in COVID, not the epithelial involvement and all. It's not just like ARDS. It is something like that. That is why many patients are having a happy hypoxia. They doesn't have much dyspnea. Dyspnea is because of this, the vessels are affected. That is why I was a little surprised to know that the COPD patients are less in the mortality list. And also happy also. The number of patients getting admitted with COPD is less nowadays. So all, contrary to our expectations, COPD patients, asthma patients are relatively safe, partly because it is due to the inhalation steroid that has been used, and partly because it is mainly the endothelial disease, not the epithelial disease.
Jodo, myself, Dr. Okemuni.
Yes.
Can I make a comment, Jodo?
Yes.
Actually, we were discussing about effect of COVID on COPD. Actually, what is the observation is, because of, we have got many COPD patients and asthma patients, actually the exacerbation rate is less during the COPD, COVID time. That is what is observed. We expect actually there's more exacerbations, either by the cause SARS-CoV-2 or by a second infection, something like that. And as our CP said, accessibility is not there for the medical service. But what observed is the exacerbation rate in asthma patient and COPD is less. That is my observation. On my own patient, there is a regular contact with all patients. Everyone is discussing contact with over the phone and WhatsApp and all, even video call. And the exacerbation rate, both group, asthma patient and COPD group, is less. The main reason what I observe is using the sanitization or the hand hygiene. That is what is, and mask. These are three things. I think there is a lot of effect of exacerbation, reduction of exacerbation by the using the mask and the sanitization. Most likely the mask, because the wearing a mask is a habit now, almost a part of the life. That made an impact on reduce the exacerbation of asthma, also COPD. I don't know, and Thomas sir and other experts are there, and Davis sir. This is my observation.
Yes, any other comments and suggestions?
One more comment I want to make.
Yes,
let me ask you, is COVID that dangerous as we expected?
COVID is dangerous for a subset of patients, and we don't have any clues.
No, the main problem with COVID is the immune response to that virus. That is the main issue. That virus has not is that dangerous, but the immune response to that is sometimes dangerous in a subset of patients. That's the mortality. Why you get mortality?
Yes,
I'm doing a study on that, sir. Actually, I am doing a study on whether it's the virus or the inflammation, which is the main game changer. I was just forwarded the protocol to the institutional board. Probably that may give you some idea about, at least in our center, whether the virus from the what you call it, the threshold and value and the inflammatory markers, what's causing the ultimate outcome or the overall prognosis. I've just forwarded the one study for that. And regarding Dr. Judo, can I tell you like a few questions I'm seeing in the chat box? One is about the all out. That's actually a insecticide from chrysanthemum, the sunflower eye, it means. And that has got the chemical called pyrethrin or the pyrethrin kind of insecticide. It's very 2000 times more potent for the insects, but not for the humans. For the humans, it's relatively less toxic. When ingested, it will be almost like having the organ of phosphorus poisoning. There will be more of secretions. There can be seizures, and there can be pulmonary edema. Those kind of. The whatever we inhale is relatively non-toxic, but the better, as Thomas sir has told, better to avoid. Then about the filters, the HEPA filter should be kept, and that too needs frequent cleaning or change. Otherwise, it's not of much use. It may add on to some infections later on. And but if the patient, the COPD patients having some asthmatic involvement, they may improve if you keep the air filter at home. Then about the last question about the glycopyrronium dosages, they were asking for it changes in various countries. Maybe 25 or 50 or 12.5 in DPAs, but maybe in MDAs it may be different. Maybe 15.6 or 19 point something like. So it depends whether it's an MDA or a DPA, and has got different dosages in different countries. That's all. Thank you.
One comment about this particular comment. That HEPA filter cannot be cleaned. HEPA filter 13 and 14 is medical grade. It can be replaced, but you cannot clean. You cannot clean HEPA filters. It can only be replaced. I have one request to the pulmonologist, because from the public health point of view, pneumoconiosis in general is underreported. This is compensatable in Workmen's Compensation Act. Under ESI also it is compensatable, but it is underreported, including silicosis and all that. Any measure we can take in this regard?
I think government is planning for that. I think while I was working in government medical college, they were asking about that, the number of pneumoconiosis patients coming to the OP and getting admitted. I think they are taking statistics about those patients who are getting admitted with pneumoconiosis.
Actually, we can diagnose, make a diagnosis and can forward the things. Whether it's a silicosis or pneumoconiosis or any cold workers or asbestos involved, we can make a diagnosis and let them. I don't know the official things to get it done.
We don't suspect and ask the occupational history. That is a problem.
Okay.
Pneumoconiosis, we are now taking CT and all. So whenever there is calcification of the lymph nodes and when there is interstitial shadows, we can easily diagnose. It's not a difficult thing.
With the history of exposure, we can.
Exposure.
So I think we had almost
We had a
running out of time.
judo.
And,
Last comment. Last comment.
yes, yes,
Actually, we had conducted study
yes.
among the furniture workers and the Thrissur district regarding the occupational disease among the due to the exposure, the wood dust and all. There is a significant amount of patient prevalence is there in that area. Not only the workers themselves and the family members and neighborhoods. Already a study conducted and published on publication.
Very good note.
Okay. So I think we'll conclude and just Prasanna Kumar, just one take-home message for today, and we'll conclude the session.
I think COPD today has moved from the pessimism of 2000 to a mild to moderate optimism of 2020. And I think what we have achieved in these 20 years is only that. We have something to tell our COPD patients and something to treat where we can make the quality of COPD patients' life better. And I think that's really what it is. It's not that animalistic disease that we had in the 2000s, for example, that was manifested even in the definition. So, one, prevent COPD. Two, suspect COPD at the earliest and get going with treatment as quickly as possible. And tell patients that if you don't treat yourself regularly, your lung function will start going down. That is the problem, because that will mean you have much better comfort. That's really the way that I would look at things now.
Okay, sir. So thank you very much. I think with the session with that, and I'll hand over to Joy sir back.
Thank you. Thank you very much. India മുഴുവൻ എനിക്ക് join ചെയ്യാൻ പറ്റിയില്ല. I was in another meeting. Now I invite Dr. Prasanna Kumar Thomas. I don't know him personally. I am saying for the first time. Anyway, I thank you personally from the IMA as IMA President for accepting our invitation and giving a wonderful talk.
Thank you, sir. My pleasure.
Thank you, sir.
Thank you.
Now I invite and other speakers and Dr. Judo, Dr. Davis, but the others are all our own members. So I'll hand over the vote of thanks to Dr. Unniyar Baby. He belongs to both the group. He's the convener of IMA IMS and he's our deputy. So over to you, Dr. Unniyar Baby, for vote of thanks.
Thank you, Joy sir. Hope I'm audible. Hello, sir. Am I audible?
Yeah, audible.
Yeah.
Hello. Yes, yes. So it's already late. I'll directly go into my duty. First of all, let me thank PK Thomas sir for his wonderful talk and on the topic Indian scenario of COPD. Thank you, sir, for accepting our invitation. It was a great pleasure and honor in hosting you. I had met you when you came to Thrissur. We wanted to get you, as Joy sir said, we wanted to get you to Thrissur this time. But in this COVID situation, we are all meeting in the virtual world. So thank you, sir, for that wonderful speech. It's always nice to hear from you. It is always wonderful learning from you, sir. Thank you so much for accepting our invitation. I also have to thank all my participants and today's faculty members, Davis Paul sir, Reni sir, and Murli CP sir for their contribution for the panel discussion. We had such a wonderful discussion. As a pulmonologist, we can go on speaking on COPD for the entire night, but we have to stop somewhere. So thank you for that wonderful discussion on COPD on 2020. Thank you, OK Mani sir, for your wonderful feedbacks and introduction. And thank you, Santosh Babu sir, and other participants for the active involvement in this meeting. I thank the president of IMA, the secretary of IMA, and the chairman of IMA, MS Indudharan sir, for his contribution for this, making this meeting a success on behalf of APT and IMA AMS. I individually thank each and every participant who came to this meeting and to make this wonderful success. And I have